Well, let's go ahead and get started this morning. Good morning, everyone. Welcome to Grand Rounds for the month of May. This morning, actually, I'm going to skip most of an introduction because the group presenting today actually has their introduction embedded into the program, which I think will be very exciting for us to hear about. So I'm going to turn it over to the UW Progress team to present today. I think it'll be very exciting.
Good morning. Thank you, Drs. Wood, Mayer, and Mark Warren for inviting us to give an update about UW Progress, our program for global and rural surgery. I'm Barclay Stewart, an assistant professor in the Division of Trauma, Burn, and Critical Care Surgery, and co-faculty lead of Progress with Drs. Rebecca Main and Sarah Greenberg. We have no real or potential conflicts of interest to disclose. We acknowledge that we live and work on the unceded lands of the Coast Salish peoples. We honor and respect both the land and the Coast Salish people who have and continue to enrich this environment and its inhabitants, including us. We have a jam-packed and exciting agenda designed to introduce you to global surgery, to Progress, what we were up to, and how you can get involved. Dr. Sarah Greenberg is going to set the stage and highlight UW's role in landmark global surgery initiatives. Then we're going to introduce you to some of our friends, collaborators, and partners from across the globe, including in Ghana, Nepal, Geneva, and in the United States, through brief recorded videos since they can't be with us today. Dr. Toby Ethelyon will present findings from our Global and Rural Surgery Engagement Survey. I'll come back to tell you a bit more about Progress and how we've structured it to support resident education, department research, and policy initiatives. A few of our trainees are going to share their work streams to give you a flavor of the activities happening within Progress. And Dr. Rebecca Main will finish things off with discussing a few of our current shortcomings, how we plan to overcome them, and how you might engage with Progress as a trainee or faculty member. I hope you enjoy hearing about what we were up to and leave with ideas on how we can work with one another and advance our mutual agendas.
Thank you, Barclay, and good morning. My name is Sarah Greenberg. I'm a pediatric surgeon at Seattle Children's Hospital and an assistant professor of surgery here at the University of Washington. I'm going to start by giving a brief overview of global surgery, specifically what it is, what we know about it, and how it has recently risen in recognition. What is global surgery? When we say global surgery, this definition, published by Anna Dare et al. In 2015, is what we mean. Global surgery is a field that aims to improve health and health equity for all who are affected by surgical conditions or have a need for surgical care, with a particular focus on underserved populations in countries of all income levels, as well as populations in crisis, such as those experiencing conflict, displacement, and disaster. To help visualize this definition and emphasize some of its components, we've put it in the form of the diagram. Global surgery aims to improve health and health equity for all, including populations in crisis, whether they be experiencing disaster from things including floods or earthquakes, or those experiencing conflict such as from war and displacement such as that faced by refugees. It also includes populations with limited access to care, including those in low and middle income countries, as well as high income countries. And this is something I really want to emphasize. Global includes local. Global surgery is not synonymous with elsewhere. Rather, it means prioritizing populations with inadequate access to surgical care regardless of the GDP of the country in which they live. Reasons for lack of access are numerable and could include things such as lack of money, limited infrastructure, lack of care providers, and differing political priorities. Access can be challenged by geographic barriers such as those faced by people living in rural regions, including many of our WAMI patients, or it can be challenged by things faced by people right here in our home communities, such as through provision of culturally inappropriate care or care provided in a language with which a patient cannot fully engage. In the fields of global surgery, rural surgery, and health equity, terms such as vulnerable, marginalized, disenfranchised, disadvantaged, and powerless are frequently used. Not only are these designations inaccurate, but they perpetuate an unacceptable culture of hierarchy and colonialism by connoting weakness, culpability, and inferiority. In reality, many of these populations have not only survived, but have figured out how to thrive while facing conditions unimaginable to many of us on the Zoom call today. A more accurate way to describe these groups is historically resilient. As Abigail Echohawk, director of Seattle's Urban Indian Health Institute, writes, "We are not a historically underserved population. My history is one of ancestors who survived so I could thrive. My history did not start with Western civilization. I am colonially underserved. I am institutionally underserved, and I am historically resilient." I'm going to transition to discuss what we know about global surgery burden and access. Surgical conditions account for approximately 1/3 of the overall global burden of disease. In addition, as many of the more traditional foci of global health, such as communicable diseases, are declining based on targeted interventions, surgical conditions are rising exponentially as a proportion of the total global burden of disease. Approximately 2/3 of the global population, or 5 billion people, cannot access safe, affordable surgical care when needed. Something as routine as appendicitis may turn into a death sentence and a fracture into a lifelong disability. This burden falls most heavily on those with limited financial resources. The poorest third of the world's population receives only 6% of procedures performed globally. This is a map of global access to safe, affordable surgical care when needed. The proportion of population without access to surgery increases as the color darkens. 93% of the population in sub-Saharan Africa and 97% of the population in South Asia do not have adequate access to surgical care. Lack of access to surgery results in significant physical, psychological, and social impacts for patients who suffer from surgical disease and the families and communities who help care for them. In addition, the financial impact of reaching care is immense. Financial catastrophe is experienced by approximately 1/4 of people who are successful in reaching care. Despite this, the reality is that many people in positions of power do not prioritize health. Most, however, will prioritize money, and the macroeconomic impact of lack of surgery is huge. Without accelerated investment in surgical scale-up to meet minimal volume standards, low and middle-income countries will have a projected loss in economic productivity of $12.3 trillion by 2030. These problems and their devastating effects have been known for a very long time. However, calls for change had largely fallen upon deaf ears, prompting global surgery to be dubbed the neglected stepchild of global health by Paul Farmer in 2008. Around 2015, however, global surgery began to gain traction within the global health development and academic communities. These are some of the reasons why. Disease Control Priorities, published by the World Bank, provides a periodic review of the most up-to-date evidence on cost-effective interventions to address the burden of disease in low-resource settings. The third edition of this included an entire volume on essential surgery for the first time and was published in 2015. Also in 2015, the Lancet, which considers itself a political NGO, prioritized surgery through the publication of the Lancet Commission on Global Surgery, demonstrating that investment in surgery was affordable, saves lives, and promotes economic growth. At the start of the first meeting of the commission, then World Bank President Jim Kim called surgery an indispensable part of healthcare. Momentum continued to build as the World Bank started including surgical measures as part of the World Development Index, and the global health and development community transitioned to a set of sustainable development goals, many of which would not be possible without surgery. Also, the World Health Organization formally recognized the essential role of surgery and trauma as part of universal health coverage, starting with the passage of Resolution 68.15 at the 68th World Health Assembly. The University of Washington team and its partners were heavily involved in all of these landmark efforts, helping to give global surgery more of the recognition it deserves and improving surgical care delivery.
Good morning, I'm Kajal Mehta. I'm a general surgery research resident and resident lead of Progress. We're so excited to share thoughts from our global and local collaborators, partners, and alumni to give you an idea of our global surgery program's rich history, ongoing collaborations, and impact. You'll be hearing from our friends in Ghana, Nepal, at Seattle Children's, and from a familiar face or two.
have had a very long-standing relationship with the Global Surgery Program at the University of Washington. My very first contact was with Professor Charles Mock, who I first met in 1995 when he was like a Fulbright scholar. And since then, he and I have collaborated on a grant, a training grant on injury, specifically strengthen injury control research in Ghana and West Africa. And over the years, we have been successful in training nearly 27 MPH PhD graduates. And many of the students who have gone on our training have also spent various times at UW, learning skills in epidemiology, statistics. Some have attended ATL's courses. My colleague, Professor Kwanzaa and myself we went to Harborview to do our ATL's course. And in the course of this engagement, we have built a lot of capacity in research. Some of the products are now the heads of departments of biostatistics in the School of Public Health. Another is the head of trauma and orthopedics in the Collaborators Teaching Hospital, and we also have one of the former head of emergency medicine, who is now the deputy director of the National Ambulance Service in emergency, and he's also one of our scholars. We had one of my colleagues who is now being promoted to professor, Adam Jedu. He's a surgeon. He also had training on the D43 as a result of our collaboration. The work that we've done has had a huge impact in Ghana. It's actually influenced policy. For instance, one of our graduates from the Building and Road Research Institute, his work informed government to actually construct road calming devices like speed humps across the whole country. And so this collaboration has been great. We've had students also from UW visit our center, and also in a kind of a bilateral form of exchange. And I would say that the strength that we have in injury research can be largely attributable to this investment and collaboration with UW. And we value that, and we hope this will continue and take new forms. This is what I would say for now. I believe that the evidence speaks for itself, but really the catalyst from your side that made it all possible was, I would say, the personal commitment and investment of Charles Mock, who is actually like an honorary Ghanaian. So I've had the privilege also of visiting UW, and many of my colleagues have also had. And we hope that the relationship will continue and take new forms, and so that we can grow. We are currently looking to extend ourselves outside Ghana to other West African countries. And we hope to be able to give account of some of the specific achievements.
I've had a relationship with UW for the past 10 years. And firstly, I received support from a UW University grant that allowed me to complete my MPH. And really, my research career took off from the time I attained my MPH. And I must say, I still continue to benefit from UW mentorship to date. So it's positively affected my career. Secondly, I also have provided mentorship for UDOC trainees, mostly through the Fogarty Global Health Fellowship Program. And these relationships and partnerships have led to conduct of meaningful research projects, which has led to some wonderful publications. Additionally, we are currently executing an NIH R21 grant to study the impact of a trauma intake form in the assessment and management of injured patients at first and second level hospitals in Ghana. And by the way, the trauma intake form came about through previous work that we had embarked upon. And more currently, we have also received a Department of Defense grant to study the effectiveness and implementation of an oral resuscitation model for moderately sized brain injuries. And so looking forward, I would like to strengthen my partnership with UDOC Global Surgery and also extend opportunities to trainees from my institution and those from UDOC.
Initiative from University of Washington taught us how to brainstorm to come for a solution of proper documentation and adequate resuscitation of protocol. And this University of Washington online courses has helped us further for the research program.
After the various brainstorming sessions, we finally came out with a resuscitation protocol sheet. Then after we introduced in our hospital, as we know that it is to be implemented with the collective effort of the doctors and nurses. So we brought our various sessions of meetings with our nurses of our burn ICU, our various wards, and then we further redesigned the protocol sheet, and we are implementing it in our hospital for now.
Yes, hospital मेरो सम्बन्ध गहिरो छ। सर्वप्रथम त बिरामीको रूपमा र यस हस्पिटलमा मैले केयर गिभरको रूपमा गर्नुका साथै स्किन ब्याङ्कमा आएर स्किन प्रोसेसिङ, स्किन हार्भेस्ट, स्किन प्रिजर्भ गर्नुका साथै हाल आएर युनिभर्सिटी अफ वासिङटनको सहायतामा मैले रेक्यापमा डाटा एन्ट्री, डाटा एनालाइसिस, डाटा एक्युरेसीमा कार्यरत गर्दछु।
म चाहिँ यस युडब्ल्यू रिसर्च प्रोजेक्टमा चाहिँ मोस्टली लजिक पार्टलाई चाहिँ हेर्दैछु। मैले यहाँ यस हस्पिटलमा डक्टर, नर्सेस, सुपरभाइजर एन्ड इन्चार्जहरूलाई चाहिँ ट्रेनिङहरू कसरी कन्डक्टको लागि चाहिँ मैले सपोर्ट गरिरहेको छु। प्लस मैले अर्को भन्नुपर्दाखेरि युडब्ल्यू रिसर्चलाई चाहिँ एकदमै थ्याङ्क दिन चाहन्छु। मैले चाहिँ ग्रुप फोकस ग्रुप इन्टरभ्यू कसरी लिने भन्ने ट्रेनिङ पनि मैले पाएँ र त्यही अनुसारको मैले फोकस ग्रुप इन्टरभ्यू पनि लिएँ। त्यसको लागि धेरै धेरै धन्यवाद छ युडब्ल्यू रिसर्च प्रोजेक्टलाई। र अर्को मैले हाम्रो डाटा कलेक्सन, हाम्रो रेक्याप सफ्टवेयर युज गरेर चाहिँ ट्याब्लेटमा डाटा इन्ट्री गर्ने काम पनि गरिरहेको छु।
Thank you, University of Washington, for bringing us all together. And we are now looking forward for the oral resuscitation program. And also thank you for the online courses, the Global Health Research Initiative, and the literacy programs. Hope there is much more yet to come. Thank you.
Namaste, everyone. My name is Yunali Mathima. I'm the research coordinator here at Kitpur Hospital in Nepal. And I just wanted to say thank you to UW Global Surgery for all the support they have shown us. The research study that we're doing here right now is an enteral-based versus IV resuscitation study. It's a feasibility study, and they've really shown us how to take something from theory to actual practice, on the ground practice. And with each barrier that we've encountered, they've been extremely supportive and encouraging and receptive to hearing what the actual problem is and helping us brainstorm a solution around it. And that's really bringing us, the team, together around this idea of implementation science so that we can effectively go forward with some of these solutions that we've come up with. In the future, I hope that UW Global Surgery will consider helping us take this forward out of Kitipur Hospital and out to the peripheral hospitals across Nepal so that patients can receive resuscitation early and have better outcomes because of it. Thank you.
SOAP stands for Surgical Equity Work Group to underscore population health. SOAP is a multidisciplinary team at Seattle Children's Hospital that was charged by Surgeon-in-Chief Dr. Jeff Ojamin in 2020. It is led by Dr. Andre Dick with the goals to delineate inequities in surgical care across the WAMI region, determine why these gaps exist, and implement methods to realize equity for children with surgical needs. WAMI, which is a very large and diverse part of the country, is the priority care delivery area for SCH. Outside of Oregon, SCH is the only ACS verified children's surgery center within the Northwest, which means that it is the only facility that has been found to have the resources necessary to generate optimal patient outcomes for children needing surgical care. This makes ensuring all children within WAMI have access an even more critical area of focus. SOAP's multidisciplinary group of physicians and partners have a broad range of expertise and have come together to work on a variety of clinical, research, and advocacy projects. As an example, core team member Dr. Juliana Bonilla Velez will give a quick overview of one of her current endeavors with the Spanish Otolaryngology Clinic.
My name is Juliana Bonilla Velez. I'm an otolaryngologist here at Seattle Children's. I'm originally from Colombia in South America, and so for me, working with the Latinx community is very close to heart and very important, I think, to my mission here at Children's. And with that effort, I've developed the Spanish Otolaryngology Clinic. We are extremely excited because we had our first launch date just last week, and it went really well. And what we're trying to accomplish really is being able to provide language concordant care to families who we know are more vulnerable to a lot of different effects of the system issues and cultural issues and language issues that can impact their care. And so we're hoping that by providing, care in their own language, especially things that are so important for families, such as taking your child to the doctor or discussing surgery, that they would be able to understand better kind of what's going on, why we're recommending what we are recommending, and all the care after surgery. And we're hoping that all of this would result in better patient outcomes for a group that we know tends to have lower outcomes than comparisons. And so we're very excited, and and so if you know of any families who prefer to speak Spanish, then please tell them about the Spanish Otolaryngology Clinic for their otolaryngologic needs. Thank you.
Hello, I'm so glad to be here to celebrate with you guys. Absolutely. The opportunities that were afforded to me by being part of the UW program have been integral to establishing a super firm foundation for my academic global surgery career. The funding opportunities really made a huge difference. And then specifically the whole spectrum of mentorship, from being super junior and showing up and just saying, who does global surgery research here? And then having projects that I got to just hop onto, to the other end of the spectrum of getting to be a co-mentor on projects with people who are just absolutely world-class in what they're doing. That has kind of framed my context and horizon for how I define excellence and accomplishment within the field. And so I'm so grateful that that's where I started. And then importantly, that network, the people that I met at the University of Washington, and then because of the Fogarty, the people I met in my research year have become my long-term community. So starting with Peru, and then the Pan American Trauma Society, and then the Center for Global Trauma Quality Improvement, this is the space that I want to spend the rest of my research career in. and these are the people who are my partners and who are the people who help me define what an important project is and with whom I get the opportunity to complete those projects. Advice for someone looking at having a career in global surgery, my favorite axiom that's relevant to this field is, if you want to go fast, go alone. If you want to go far, go together. And so I think having teams that are comprised of people with different strengths and backgrounds and experiences has just been such an opportunity for me and has been so effective in understanding what a meaningful project is and how to get it done. And so I would say, practically speaking, as a trainee, find someone who you respect, who you have any overlap in clinical topic of interest or region of interest or research methodology, and then do the next right thing. Lean into that opportunity and see where it leads you. With regard to pitfalls and transitioning from training to a faculty position, I think I'd recommend being super discreet and concrete in your contract, as much as you can, about how much time for research or global surgery, however you're doing it, and then how much time that means you're not doing for other clinical things, and just to make sure that everything is super well documented and transparent. And then finally, I would say to be creative and define your own success, to know what matters to you and why it matters, and then whether there's a precedent or not to pursue that is such a privilege. So again, congratulations to everybody. Hope you guys have a wonderful day.
Good morning, I'm Toby Afly. I'm one of the General Surgery Chief Residents. I would now like to talk to you about our Global Surgery Engagement Survey. Last fall, we used the survey to understand the global surgery interest among our trainees and to understand how trainees would like to engage and what they would envision in a global surgery training program. We had 27 respondents among general, plastic, and vascular surgery trainees. We expected that only those who were truly interested in global surgery will likely complete the survey. Thus, this also highlights the level of global surgery interest among our trainees in the department. Now, while not all our trainees came to University of Washington, particularly for global surgery training, a majority of our respondents were interested in global surgery training at the beginning. The majority of respondents also have career goals in global surgery at varying levels. Those trainees were interested in many educational programs that would help prepare for those careers. Now, when given the option, trainees wanted all aspects of available activities. Through this survey, we're able to understand what success would look like at the end of a global surgery training program at the University of Washington. We have a robust cohort of trainees with vested interest in rural and global surgery. There is particularly interest in clinical and research opportunities, which can be developed with a variety of activities, including journal club, didactics, visiting speakers, work in progress sessions, and clinical skills development. Now, these meetings currently occur monthly. Thank you.
I'm back for a bit to introduce you to UW Progress. Given the breadth of interests and opportunities within global surgery, as well as our focus on training, we established our vision to inspire and empower future surgeons to improve health and equity locally and globally. To achieve that vision, we will develop future leaders in surgery to discover and create dignified, justice-oriented, and sustainable improvements to the health and care of vulnerable populations, particularly those who are at risk for or have experienced surgical conditions or injuries. Progress has three key functions: education and training, research and dissemination, and lastly, policy and programming. I'll give more details about each one of these. Our first core function is education. And the following few figures on the next slides, darker purple indicates that we are making strides and little additional resources are required. Lighter purple indicates that we still have significant hurdles with regard to strategy, logistics, and or funding for those activities. We currently have monthly seminars that take the form of journal club, works in progress meetings, or invited lectures. We are working to develop a case study series that builds problem solving and connections within our partners outside of the University of Washington. We are creating a curriculum based on text and manuscripts but aim to develop an online-based modular curriculum in the future that offers more interaction, tracking, and certification for our trainees and those of our partners. We have already leveraged the university's online certificates and course programs for our trainees, but would like to augment those with clinical education in the form of multi-specialty boot camps, global surgery courses, and rural and/or international clinical experiences. We have developed foundations of strong research built by Drs. Charles Mock and Ben Anderson, for examples. Taking their lead, we currently match trainees to ideal research mentors from the UW and beyond, support ongoing research and future presentations through works in progress meetings, and leverage the NIH Fogarty Global Health Research Fellowship to financially support our trainees in the 5+2 track during their research years or after their clinical fellowships. We want to strategically increase our attendance at key global health meetings and consider sustainable research training funding through both individual and institutional training grants. Lastly, we are very active in several professional societies and global surgery committees as residents and faculty. We also have two residents, Drs. Kajal Mehta and Ben Massenberg, in leadership positions at the American College of Surgeons Resident Associate Society Global Surgery Working Group. We have already elevated the conversation and activities within the RAS. We have a long, productive relationship with the World Health Organization, in large part thanks again to Drs. Mock and Anderson and Dr. Andrea Bali, who works in the Cancer Control Unit since this fellowship. As a result, we have supported at least 5 trainees as either formal WHO interns or with consultation projects as team members. Given this history and activity with the WHO, both past and present, we are working toward being the second WHO collaborating center for injury in partnership with the Kwame Nkrumah University of Science and Technology in Ghana. All of this work is priceless, but it's not costless. We are grateful for the department's support and motivation to grow progress, and are actively pursuing a number of other potential funding streams to support our work. We have received awards and funding from the university, industry, external grants, and non-governmental organizations. We aim to expand these avenues and develop opportunities for individuals and organizations who want to donate to progress to support our mission.
Hello again. Now we're going to dive into examples of our ongoing project work streams to give you an idea of the breadth and depth of our current projects and collaborations. I'll be starting off. This series of projects and research arc focuses on the concept of enteral-based or oral resuscitation using oral rehydration solution for the treatment of major burn injuries. There is a lack of access to resuscitation after major burn injuries in a variety of resource-constrained settings, including low- and middle-income countries, multiple casualty incidents, and battlefield incidents requiring prolonged field care. Thus, without access to timely resuscitation that is typically administered intravenously, the mortality rates for these often survivable injuries is exceedingly high. Given the potential operational advantages of enteral-based resuscitation, we're aiming to study the effectiveness of and key implementation points for successful enteral-based resuscitation. And as there's no available protocol or guidance for this method of resuscitation, we aim to develop and disseminate the world's first enterally based resuscitation protocol and implementation toolkit for major burn injuries. Our collaborators include the Nepal Clefton Burn Center, the Kwame Nkrumah University of Science and Technology, and the U.S. Army Institute for Surgical Research, as well as the U.S. Department of Defense Military Burn Research Program. We've been awarded 2 years of funding for this project through the NIH Fogarty Global Health Research Fellowship. We're currently conducting a feasibility study, and in the next year, we'll be completing a pilot study of the enteral resuscitation protocol and bundle that we've developed with stakeholders and collaborators in Nepal. We're also using the Delphi methodology to build expert consensus from burn providers globally on this protocol. Additionally, we've been able to complete a geospatial location allocation modeling exercise, which has helped us identify the most strategic first-level hospitals in Nepal to build capacity as burn stabilization centers and to ultimately disseminate our enteral resuscitation bundle too. And lastly, through funding support from the Department of Defense, in the coming years, we'll use lessons learned from our Fogarty studies in Nepal to inform and carry out a cluster randomized effectiveness implementation trial of enteral-based versus IV resuscitation for burn injuries at first-level hospitals in Ghana. We hope that the results of this trial can help improve the treatment and outcome of burn-injured patients globally.
Hello, my name is Dina Messick, and I'm a second-year PhD student in the Implementation Science program in the Department of Global Health, and I'll be presenting on the road traffic injury prevention work in Ghana. And so to provide a bit of background, so road traffic injury and prevention mortality reduction efforts have been very successful in high-income countries, but that success has not translated to low or middle-income countries. And specifically, some of the interventions that have worked around, reducing drinking and driving, seat belts, improving cars and adding safety features will not and have not worked in low resource settings. As such, there's a need to study the context and relevant risk factors for low or middle income countries. The goal of this work is overall to inform the scale up of evidence-based road safety initiatives in Ghana and other settings to reduce both injury and mortality from road crashes. And so some of the collaborators we're working with are the Kwame Nkrumah University of Science Technology, the National Road Safety Authority, the Building and Road Research Institute, as well as many other in-country partners that are interested in reducing road injuries and fatalities. And the funding for this work comes from the NIH Fogarty International Center. And then in terms of the work that we're setting out to do, in Ghana, there is a comprehensive database of all car crashes that have occurred for the last 20 or so years. And so using this secondary data, we're intending on doing a couple of major activities. The first of which is bringing together a multidisciplinary road traffic safety working group, which will allow us to use this data to determine what are the most relevant research and evaluation priorities in Ghana. Using the same database that I mentioned, we're intending on linking all of the data on car crashes, which includes, the location, the time, the conditions, and were there any injuries, were there any deaths, et cetera, with additional road network data, vehicle and traffic data, and the built environment information. And through this database, we'll be able to look at geospatial trends in road traffic injuries and deaths. And then lastly, using and utilizing the multidisciplinary road traffic safety group, we're going to answer questions that they deem most important and urgent to address road traffic injuries and fatalities. And so these will include questions such as, through natural experiments, what types of interventions have worked? So, whether it be traffic diversion or adding sidewalks, adding cycle lanes, etc. And those are the main milestones associated with this work, which we intend on starting in July of this year and continue on for the next year.
My name is Hannah Wild, and I'm a general surgery intern at the University of Washington. I'll be speaking briefly regarding our partnership with the United Nations Mine Action Service, which I'll refer to as UNMAS, to reduce injury and mortality related to landmines and other unexploded ordnance. This project came into being as UNMAS is currently revising their organizational mandate. Two key pillars under this revised mandate include A, more closely integrating mine action with humanitarian response, and in particular, the health response to blast injury, and B, leveraging and building new partnerships in order to augment their institutional capacity. In this context, we reached out to their leadership, thinking that UW's institutional expertise in reducing trauma-related mortality in low-resource settings would be particularly applicable. We asked them what key questions or gaps we could use our research capacity to address in order to further their operations and advocacy efforts. They came back to us with a problem on this slide, namely, at present, approximately 1 in 3 victims of landmine and other unexploded ordnance die of their injuries. They asked us precisely what it would take to reduce this number to 1 in 10. Currently, we're working to develop a project that will answer this question. We'll start with background work, conducting a scope and review of interventions that have been demonstrated to reduce mortality, both related to blast injury and landmines in low resource settings, as well as to broadly reducing trauma-related mortality in low resource settings. This will build largely off of work previously conducted by Dr. Stewart in the WHO. We'll supplement this by sector expert interviews, identifying interventions that, if they have not been demonstrated to do so, trauma experts in austere settings feel have capacity to be beneficial in this context. We'll then model these interventions across an integrated chain of care from point of injury through pre-hospital transport all the way to formal health facility. Such interventions may include, for example, Stop the Bleed, lay first responder training, which has demonstrated efficacy in settings such as Iraq and Cambodia, bicycle ambulances featured here. We'll work with UNMAS to identify 3 countries which we can use as case examples. These will either be of particular organizational priority or will exemplify different conflict topologies, such as urban conflict in Syria and Yemen versus more rural conflict as in Nigeria or South Sudan. Once we've built this model, we'll either use in-country data or, where not available, proxy measures to try and estimate the potential for mortality and morbidity reduction. After doing so, we'll work with our local partners to develop a dissemination kit and standardized material for mine action stakeholders and health providers. We hope that this will serve as a foundation off of which we can build towards a longitudinal partnership with UNMAS.
Good morning. My name is Chris Marfo, and I'm a third-year general surgery resident at the University of Washington. I'll be briefly discussing our collaboration with the World Health Organization and International Association for Trauma Surgery and Intensive Care to develop a trauma surgical course that is applicable and accessible in low-resource environments. It is well known that the burden of injury is high and disproportionately affect patients in low and middle income countries, where 9 out of 10 patients lack access to the most basic surgical care. Often, injured patients in these settings present to first-level hospitals and care facilities and encounter providers who lack the basic necessary resources and sometimes the surgical skills required to provide the highest level of surgical care for these patients, thus worsening the morbidity and mortality associated with injury. As surgical residents and attendants, we understand the importance of maintaining our surgical skills and the impact that has on patient care. In this regard, many trauma surgery skill courses have been developed to enhance the knowledge and skill set of providers and practitioners providing care for the injured. Many of these courses are well known to some of us and include the Advanced Surgical Skills and Exposure in Trauma course offered by the American College of Surgeons and the Definitive Surgical Skills and Trauma course offered by the Royal College of Surgeons, just to mention a few. However, many of these courses are oriented towards providers in high and middle income countries or are expensive, resource intensive, and inaccessible to providers in low and middle income countries. Therein lies the need and the goal of this project to inform the development of an affordable, contextually appropriate, and resource sensitive trauma surgery course. The collaborators for this project will be the World Health Organization and International Association for Trauma Surgery and Intensive Care. To accomplish this goal, we'll be performing a scoping review of all trauma surgery courses being delivered globally to identify and extract key information relating to the scope, content, resource requirements, cost, and many other factors affecting these courses. We'll subsequently interview sector experts on course development and implementation in low and middle income countries. Armed with this knowledge, we'll create an internal report and present that information to the World Health Organization and International Association for Trauma Surgery and Intensive Care to facilitate the development of such a course. We hope that through this project, we'll be able to contribute to the development of a course that bridges the gap in trauma surgery care. Thank you.
Good morning. I'm Rebecca Main. I'm one of the trauma and acute care surgery attendings at Harborview. And for the past 12 years, my research is focused on surgical systems and improving surgical outcomes in low resource settings, including Ecuador, Malawi, Rwanda, South Africa. Appreciate the opportunity to discuss our next steps and key concerns moving forward. As with any new program, there remain several opportunities for growth, as well as several challenges to establishing sustainability. As you have seen, there's tremendous knowledge and experience at the University of Washington in global health, both in the Department of Surgery and across other departments. We aim to leverage this experience to develop bi-directional learning opportunities
shaped by the needs of different learners, both at our institution and our partnering institutions. While not every resident will focus their long-term career on rural or global surgical equity, many can benefit from a mentored, focused rural or international experience. The evidence finds that residents who have these international rotations have productive surgical experiences, encounter novel disease processes, and learn the innovative ways that surgeons practice in these limited resource settings address the challenges to provide optimal care for their patients. Sustainability in this kind of bidirectional learning depends on identifying an appropriate site or sites, ensuring that our training goals are aligned with our partners, and that we develop an appropriate curriculum to meet those goals, that we identify the appropriate faculty to provide oversight, and that there is coverage for residents who want to pursue this elective. As we build this and other parts of the UW Progress program, we have the opportunity to develop and establish our areas of expertise in the field. The breadth and depth of global surgical work done by members of this department in many ways serves as an example for how to build a global surgical program. Yet, as the field of global surgery expands its focus to include equity in many settings around the world, we have the opportunity to grow and refine our focus and expertise. Our relationship with the WAMI region and connections to healthcare organizations around the world provide us a unique opportunity to think broadly about how to best apply solutions for surgical equity across many settings. We look forward to the novel collaborations within this department that this broader focus and expertise can bring. We have lofty goals, and while our enthusiasm is strong and we are supported by a group of passionate residents, medical students, and faculty, without additional support, the long-term success may be at risk. We want to ensure that trainees have access to a variety of ways to engage with global surgery, whether they are planning a dedicated research time abroad or just want to learn more about the topic. Part of this will involve growing and establishing long-term research partnerships that will allow interested residents to identify meaningful projects that can contribute to the issues prioritized by our partners. Longer-term training grants may help to support these goals. We also want to ensure that we have the support to foster the interests of individuals who want to pursue a specific interest or passion. For the residents and fellows who are interested in making academic global surgery a career, we want to ensure that they, like other research trainees, have experience with grant writing, as well as developing and executing projects. We would also like them to be able to pursue additional degrees if that would be beneficial for their training. To support the residents going forward, we need to establish a long-term funding mechanism. Like many research labs, we anticipate that some of our funding will come from grants. Unfortunately, the NIH has many restrictions on internationally focused grants, and there are fewer calls for work in the international setting. Fortunately, we know that there are many people in the department and across the university who have been successful at getting funds, and we look forward to their suggestions to help us be as competitive as possible as we pursue this and potential training grants. However, it is unlikely that grants alone will fund all of our work. We will need support from the Development Office to establish an endowment that can maintain the success of the program going forward. Part of that will be supporting administration to make sure that as we execute and work in these many settings around the world, that we are always achieving our highest quality and maintaining our ideals to support our goals. How can you engage with UW Progress? First, get involved. We're completing our website right now. When it's fully functional, we will share the link with the department. On the website, you'll be able to find updates about the work that's going on around the world. You will also be able to find our calendar, which will have our schedule of monthly events, including speakers, journal clubs, and works in progress. We encourage anybody to attend these events, especially people with particular research expertise that may be able to provide a different perspective to our trainees, partners, and faculty in their global surgery work. We also want to ensure that we can serve as a central way for the department to keep track of the global activities, to make sure that we are fostering all of the connection and collaboration that can be beneficial. Please let us know what work you are doing in rural, indigenous, or global surgery, so that we can communicate it more broadly and help you identify folks that may be able to help you grow your relationship or provide additional support for your partners. Finally, We hope that you will walk away with this presentation, with an appreciation that as the field of global surgery has developed, in part due to the leadership from surgeons in this department, it has progressed from understanding and acknowledging there's a role of surgery in healthcare around the world to focusing on ensuring equity in surgical access and outcomes across the globe. To do this well, individuals who may not have traditionally thought that their work was focused on global topics are needed to bring their expertise and perspective to help maximize our impact. As such, we would love to hear what skills you might have to offer as a mentor, either for research or clinical teaching in any of the areas where we work. We're very excited by the opportunity to continue to grow and transform the field of global surgical care. And with your help, we can all progress.
Thanks everyone for your attention and for listening. Certainly I just wanted, before we open it up for questions, I wanted to highlight Dr. Kajal Mehta, who spent an extraordinary amount of time organizing the videos and organizing us, quite frankly. And then Michael Hillary, who supported all the editing of the video and did above and beyond his usual administration duties. We very much appreciate their contributions to pulling this together.
Yes, Barclay, thank you for calling out Dr. Mehta and Michael Hillary, because that's a pretty impressive video you guys put together. I'm trying to picture the amount of work of pulling everyone together like that, but what a diverse presentation of collaborations around the world, different levels of projects and impact from trainees to faculty and visions for the future. You know, I hope everyone else found that as inspiring as I do. And, you know, I had a meeting with our advancement partner yesterday, and, you know, the slide couple of slides ago from Dr. Main, identifying philanthropy as an important aspect. I recognize that the challenge for all of this is funding. That unlike other areas of kind of, I guess, more traditional basic science or clinical research, it's been hard to find reliable and strong funding mechanisms. And, you know, when I think about the community that we are in, the Seattle community, and its global perspective, meaning of the substantial philanthropists that we have in the community, it makes me try to figure out ways that we can capture some of that, engage their involvement, and see if we could use philanthropy to create a funding groundwork that can keep this program stable and growing, recognizing it's not going to be the only thing, but that could at least provide some stability to the funding for global surgery.
Yeah, thanks, Dr. Wood. We certainly acknowledge all the support that you and the department have provided us with to build this foundation, and more importantly, very many years of faculty working very hard to develop research programs like Dr. Mock and Dr. Anderson, for instance, who have set us up with a really great insights and opportunities to get grants. We've been successful in starting off with some grants to support trainees, but for all the other activities that are really the core of a global surgery and rural surgery education program, those aren't going to come from grants, as you mentioned. And the training grants available for international work and even rural work are quite sparse and have been often received time and again by a single organization. So we've been introduced to the advancement group, and we are building a package of information to help identify and to give opportunities for those interested in supporting the program, an opportunity to contribute. We hope that that'll work as time goes on.
Yeah, exactly.
There is a question from Dr. Mock. Dr. Mock asks, in general, how can faculty collaborate with Progress? What are those feasible next steps for collaborative work with these departments? Rebecca, since you talked about it a touch at the end, do you want to answer this one? Sorry to put you on the spot.
Sure. Yeah, that's okay. Thanks. So I do think that one of our first steps is really to start organizing people who are interested and getting some ideas of what people are doing and who might be interested in helping this effort, and sort of saying what is out there. And I think the connections that we have through other organizations at the University of Washington, like HIPRC and the START Center, are other ways that we can identify people who are doing work in similar fields that may really have strong collaboration. So I think the first step for folks in our department is to reach out to us. So email us, let us know what you're doing and interested in doing, and how you'd like to engage. And I think this starts to get a little bit at the next question from Dr. Olschlager as well, which is we recognize that not everybody is going to have months and months of additional time to support us. So I think when you reach out, say what kind of time commitment you'd be interested in doing, and I think we have plenty of opportunities to match people with trainees and faculty and projects that may be mutually beneficial for whatever amount of time and commitment you're able to give.
And just to follow on with Dr. Olschlager's question about faculty interested in contributing perhaps hours, days, or a bit longer time. For each of the monthly seminars, we are looking for people interested in providing a lecture or a collaborator to discuss some issues very pertinent to rural and global surgery. And I know that a lot of faculty in the department have expertise and insights in specific elements of what global and rural surgery entail. Additionally, we're developing case-based projects to help teach global and rural surgery paradigms, approaches, and methodologies, and without require partners both within the department and outside the department as experts in that field to be able to adjudicate, if you will, the ideas that each of the small groups within Progress develop as ways to answer the case-based problem. So we'll reach out for those opportunities, and please, if anyone's interested, we look forward to collaborating. And then lastly, Dr. Shahu mentions aortic dissection as something that is understudied in under-resourced areas of the world, and care for people affected by this seems to be a luxury due to heavy resource utilization. How does one begin to address high-cost diagnosis? Sarah, do you want to take this one?
Yes, I think it's very dependent on the setting and the resources available in that setting, but depending on the site and if this is something that people are actually seeing, or if not, if it's something that the patients can't reach hospitals in time, I think reaching out to us and our collaborators to help develop partnerships and to see whether there are collaborators that have this area of focus and how we can help would be a good place to start.
And just as we close and to follow on, there's two interesting initiatives that might be interested to you. One is Boston Scientific has developed this program called Close the Gap, which obviously intends to increase their market share globally, but also has the side effect of finding ways to bring relatively high-cost interventions to most of the world who currently don't have access. And they have small grant opportunities for people interested in identifying those interventions and opportunities. And the second is Prof. Herb Yangate, who's the recent past president of the West African College of Surgeons, is working on developing a Pan-African vascular registry. And I'm not sure what he has in it for aortic disease, but is working with hospitals across the continent who perform vascular operations to find ways to identify quality improvement and resource-specific benchmarks for vascular care.
All right, I think we have reached our time, unfortunately, for ending this fantastic programs. Dr. Greenberg, Stewart, Dr. Main, Dr. Mehta, thank you for a fantastic presentation. And I'm sure you will be receiving some emails from the faculty after this today. Thanks, everybody. Have a great day.